Hi everyone, my name is Melanie Grant, and this is a recording for our 2030 CPT class looking at abstracting for some of our E&Ms this week. We're going to look at charts 1 through 5, which we will be discussing in the discussion for Module 8. Let's take a look. So here we have our charts 1 through 5 that are attached as part of this week's discussion. Chart 1 has been highlighted and marked up for you, and there's a few things you'll want to take note of as you review through everything in this note. The idea of this discussion is simply to put it together. You have 4 of these charts which are going to be in a family practice office or office and other outpatient visit, and 1 that will be in the emergency department and require a few different things to be looked at. For chart number 1, we see here the reason or the chief complaint for the visit is that they have neck pain and they're following up on labs and referrals, meaning that the patient has been seen previously by this provider, and we're going over a couple of different things. Certain elements that you may find in some office visits when you're looking at exam and history as part of the key components for selecting your visit include things like where we collect the vitals or the severity of their pain when documenting for items like HPI. We can also see certain details about the note. So let's look at this in more detail. All of the information that's pulled in here is automatically pulled in through the EHR based off of information the nurse or MA has selected in the visit before the provider sees the patient. You can see here the progress note starts here where the MD has authored and signed the following information. And they pull in some of this information automatically from what's already been listed, like neck pain, follow up on labs and referrals. Not only can we tell that this has been pulled in because it's exactly the same, but there's also a typo in the exact same spot in the reason for visit that the provider has put in the reason for the chief complaint, which means that it's the provider's review of what's already been selected, and that's perfectly fine. There's details here about HPI. Now, we don't require history as a main component for your office visits any longer, but I've highlighted some of these so you can see what we would pull out of this when looking at different levels of HPI to select the level of history, because in other types of visits, it is still counted and relevant. If I wanted to follow along, I can pull up the Novitas website at novitas-solutions.com. And I can select all the information that's pertinent to my visit. So I am in New Mexico, jurisdiction JH or H. And from here on the Novitas website, I want to go to the evaluation and management and download the scorecards or score sheets. To look at the 1995 E&M guidelines, I can select the PDF here. And to look at the general multi-system exam for 1997, I can see the PDF here. So I'm going to select both of these because I want to have them available and able to be used. I'm also going to download them to my computer directly because I want to be able to highlight on these, and I can do that by taking screenshots, or if I have a PDF editor, I can do that directly in my PDF. So let me download this to my desktop here. This is the 1997 exam guidelines. And I'll download this one, which is the 1995 scorecard, because it's a full scorecard, not just the exam. And so I'm putting those both on my desktop, which I will of course delete later. Now I can go over to my PDF and I can open these so I have them available while I'm working. Perfect. Okay, so I'm ready to look at this. If I wanted to branch some of this information from chart one, this is just an example. So we won't be using, of course, the HPI or the different elements for history in office visits. So the first thing you want to say is, what do I need to use? So obviously all the things that are highlighted, we don't necessarily need those in these specialty scorecards. Instead, we need to have access, and I'm going to go back to my Novitas site here, to the AMA's revised CPT guidance, which gives us on page 7 the medical decision-making chart. Or you can look this up directly on the AMA 2021 MDM table to have that chart downloaded and available to you. I'm going to do that here. I like this version better instead of the full guideline. This whole guidelines, it's 16 pages. It has great details on the differences, but we've covered most of these in our class. And if you're just using the scorecard, it's just easier to pull up the AMA 2021 MDM table, as I showed you here and as I've provided you in class. So I'm just going to go ahead and download this one as well and save it to my desktop. And then I'm going to pull it up also in my PDF. Perfect. And I'm actually going to move this over because I want that one available first. So when I'm looking at this chart number 1, there's a few things I can do. Of course, I can look at all the history and elements that would have been used had we been using the 95 or 97 guidelines, but I don't need to for this purpose. So let's just go ahead and not select those. Let's keep those as references for where we would find information. And let's continue looking on here using the office and other outpatient services for the revised MDM scorecard that's used by the AMA for 2021. So the first thing I want to say is, what are the number and complexities of the problems addressed? So I'm going to read through here and I'm going to see all the information I've highlighted for chart number 1. First, I see that we have information. They're addressing a neck pain, which is a previous visit. There's a severity of 5 that's listed. There's a notation here that I've made of acute uncomplicated. We can see here that it's an established problem. They also have hypertension, which is a known chronic problem. The neck pain is assessed here, and this is actually where the acute uncomplicated should be. It's next to the neck pain. So let's kind of put that there, make that more clear. So the neck pain is not considered chronic. There's nothing indicating that it's chronic. And from all of the information here, there's nothing indicating that it's becoming worse or complicated. So we would consider it uncomplicated. We will, of course, look at the plan to make sure that there's no additional uncertainty about it that might indicate a potential for unknown prognosis with an undiagnosed condition. Okay, so we have here in our HPI, we have hypertension, which is a known chronic problem, neck pain, which is the primary focus, and acute uncomplicated. And we can tell that by reading through the note. And we also have a headache that just started recently. And this is a new problem, and we want to see what the provider has to say about that. There's also things like reviewing labs and x-rays, which doesn't specify exactly which ones necessarily, but so long as there's something in here that would support that, we want to take note of that for our data elements. We have some past history that's reviewed, social histories. So all this is your PFISH. Information about where they live, who they live with, the medications they're currently taking, and their review systems. We also have repeated vitals here and a fairly detailed exam. And we can see it by the highlights and the marks that there's 10 elements on this exam that's looked at if we were counting exam elements. Again, with the new office and outpatient services, we don't need to count the exam elements, but I would want to read through this to see if there's anything in the exam that's noted that might indicate the type of problem or the complexity that would bring me to something greater than an acute, uncomplicated problem. So under the neck, they do indicate that the neck twists back and forth and it's unable to hold head still during the physical exam, but they were able to sit without problems, it looks like, during the actual questioning. So I would not put that as a complicated statement. I would look to see if the provider made it sound complicated. And here's our assessment and plan. So you'll notice this is a SOAP note, the subjective or S, which includes all of the information of their history, why they're here, what they've done in the past, and any additional symptoms they may have had. The O for objective, which is the physical findings, and the A and P, which is the diagnosis, and then the plan for each diagnosis. And this provider's combined both together. So I can come in here and I see we have a more specified diagnosis. There's a muscle spasm of the cervical muscle of the neck. So they've made this more of a specified diagnosis rather than saying neck pain. They're saying what the cause is. So it's not undiagnosed. They are recommending physical therapy and heat, and the medication's already given. And they've given a referral. Under the headache, the exam is non-focal, meaning there was nothing really found from it, nothing of concern. Encouraged to continue staying well hydrated, get rest, relax. You can try some over-the-counter meds. And so we can see this is assessed as acute uncomplicated as well, even though it's a newer problem. And presumably from the lab review, hypertension is stable and controlled, and they're continuing with their chronic medication. So one thing I would point out, there's a notation previously of reviewing lab results and x-rays, but there's nowhere in here that tells us what those were or what the results were. And so without that, we wouldn't be able to count those. Let's go ahead and see how we can map this. I'm going to use my highlighter and I'm going to highlight all the different areas that I have seen. We have an acute, uncomplicated illness or injury, and we actually have two of those. You'll notice there's not a selection for two acute, uncomplicated illnesses or injuries. It's just one acute. So in this instance, for the number of complexity and problems, when it should say one or more, and that's something maybe to think of. One or more chronic illnesses with exacerbation would not apply to our patient because they had a stable chronic problem and there was only one of them for the hypertension. And so this would also fall under the low section for number of complexity and problems addressed. Now keep in mind, for office and other outpatient services, we base our visit off of 2 out of 3 elements of MDM. So our first one is low. Our second category, we may have to review the note again. Now, we go through these and say, okay, is there anything from category 1 that's indicated? Did they review prior notes from a previous encounter? And if so, they would have had to have listed that. I didn't see anything in there. I can, of course, go back and re-review everything, but keep in mind, just putting in information from the system, like all of this really great elements on their history, that's not necessarily a review of private notes. That's information that's available to the provider directly in front of them, just as if they had the medical record in front of them. Prior notes would be something like they were seen in an ER visit or by another provider. So I would not count that. Reviewing of each unique test and or ordering of each unique test. Now, they had this note reviewed lab results, but they didn't tell us what it was or the x-rays. So I can't count that. I can look down here in the plan and see if they ordered any new labs or x-rays or any types of tests. They encouraged physical therapy, talked about treatment, but there was nothing in here ordering tests. And so I can't I cannot select anything from category 1, and there's no assessment requiring an independent historian, meaning that they didn't get the information of the patient from someone other than the patient. So in this case, I'm actually going to select minimal or none. I can look through categories 2 and 3, but these are going to be more in depth than what I had in category 1. For example, under a moderate level of the complexity of data, category 2 is independent interpretation of tests. So those labs and x-rays that they reviewed, if they have independently ran the results of the labs and looked under a microscope, or if they had reviewed the actual x-ray imaging and made their own assessment, that could have been counted. And they may very well have done that. But if it's not documented, it didn't happen. And discussion of management or test interpretation would be if they had called the actual pathologist with the labs, which is very unlikely with normal labs. That would be more for specimens. Or if they had called the radiologist to go over findings on an x-ray. Again, there's nothing documented that this happened. And categories 1, 2, and 3 for a high level of data are those same things, just requiring more of them. So I feel confident selecting minimal or none here and going on to my third area. Under risk of complications and or morbidity, the first thing I can say is that yes, there does seem to be a low risk for additional diagnostic testing or treatment because there was nothing indicating any concerns or complications. They're encouraging them to go with physical therapy and use some heat on their neck. There's nothing saying here, be careful of doing certain exercises or activities that might indicate that there was some types of risk from this. They're encouraging them to still stay well hydrated and take some over-the-counter meds if your headache doesn't resolve. Most likely, they came into the office and just mentioned they had had a headache for a few days. Very likely, that headache's possibly related to the muscle spasm in the neck. And then as far as the hypertension, there's nothing indicating any concern. In fact, it's stable. So going back to my medical decision-making chart, this would be a low risk morbidity. However, there is prescription drug management. And so anytime there is prescription drug management, that's going to bring you to a slightly higher level of risk. Even though it's just one prescription that's being continued, there is detail in the note as to what they're taking. They did assess the hypertension and say that it was stable and determine that it was okay to continue with the current regimen. However, even with stable hypertension or a chronic condition, any decision about the medical treatment is always going to be counted under prescription drug management when a prescription is involved. So that would make this a moderate level of risk rather than the low. The last thing we do is we say, I need 2 of the 3 categories that are highest. And here we only have the low that's met at 1 level, the minimal, which is straightforward, and moderate. So we're in 3 different categories. So the thing we want to do is we want to determine what's included if we are at a low, a minimal, or a moderate. So going back to number of complexity and problems addressed, the requirements for a low level of complexity also meet the requirements for minimal. And so we can see here that now there are 2 levels meeting in a minimal level for straightforward medical decision making. However, the same thing applies here under risk of complications. The requirements to meet a moderate level of risk also meet the requirements for a low level of risk and a minimal level of risk. And so we have 1 section that meets a moderate level of medical decision making, 2 sections that meet a low medical decision making, and all 3 that meet a straightforward medical decision making. And then of course the 99211, which is used strictly for nurses. So now we have 2 categories that meet 2 or more elements of medical decision making, and we code based off of the highest level of service. This patient is considered established, so our code for this visit is a 99213. Simple enough. Moving on to chart number 2. I haven't highlighted everything for you, but as you're going through it, pay attention to things like family health care for an office visit and terminology like NTP, which means new to the provider. You'll see a lot of the same setup as in the previous visit. And keep in mind, you're looking for documentation about either medical decision-making or time. Our last one didn't have any documentation of time, even though they had things like what time the provider put the note in or what time the patient was seen. There needs to be a statement of the provider's time in the provider's documentation to count time as an element. We can see here that this patient is being seen for diabetes as a new patient. There's details about the diabetes. They also have a history of hepatitis C and GERD, as well as DES exposure in the utero. There's some past medical, family, social histories all pulled in, as well as current prescriptions, and a fairly detailed review of systems. Again, not all of this is going to be used in your selection, but it's important to take note of. They've also done a fairly extensive exam with a couple of things which they've bolded for us to see abnormalities. Providers will sometimes bold information or make it in red when they feel that it's something relevant, like the lab results here that they've pulled in. In fact, take note that we do have a lab result here for this patient. Obviously, no results found for other labs would not be counted as an individual lab because there were no results. And they've ordered a slew of different information. They've assessed the patient with diabetes type 2 without complication and then said it was uncontrolled. That might be an option for a query because if it's considered without complication, then it's not considered uncontrolled. They've ordered a couple of tests as well as medications. And so you'll want to root through these to see what's going on. The hepatitis C seems to be uncomplicated, and just more of a note on file. As with the GERD, they did diagnose a new problem of candidiasis of the mouth and skin, and they've ordered some routine lab testing. Chart number 3, you'll also notice is an office visit in the family practice. Patient is seen for knee pain and hip pain. There's some information about the time since this has happened. And they're saying declined health maintenance check, which is just simply saying that the provider may have wanted to do a physical with the patient, and they said, no, I'm just here for my knee pain, thank you. There's some details about the knee pain. And it seems like the hip pain is possibly related to that. It does mention the groin area here. So that would be referred pain. There's a lot of information about their history. Again, this is pulled in from the system by the provider. A brief review of systems, fairly focused exam, and assessment here. There is a suspect for a different condition, so they're not sure what's going on with the patient. Although, based off of the information here, they may have an uncertain prognosis since they're sending in for additional labs and x-rays. In fact, they're doing evaluation and treat with physical therapy, which would in fact support the fact that the prognosis is unknown. So what kind of condition is that? Chart number 4 is a diabetes follow-up new to provider, which I would query the provider and say, are you following up on their diabetes? And have they been seen in the office, or are they following up themselves because they need to get a new provider? It's very likely that this office had seen the patient before by another provider of the same specialty. And there should be some sort of documentation in the note that would support that. If you need to query the provider, remember to treat me as if I am the provider and send me a query. There's also an additional procedure done by the licensed nurse. And they're also getting some sunwork or paperwork from Sunwork. I'm assuming this would be something to do with their job or residency. We can see information here about their current diabetes, and it seems like they have a fairly good regimen that they're following. Hypertension, which is assessed, and hyperlipidemia. So that's 3 different chronic conditions, by the way. Past medical and family histories, social histories, current medications, and review systems. There is some questions about some of the review systems that you'll notice are not noted in the HPI. So you would pick that up if the provider decides to treat for something here. There's also some notes here in the exam, such as the ear canals being blocked with cerumen, which supports the procedure that the nurse did to clear out the ear canal. They did pull in some lab results and put in their assessment here, along with several labs to be ordered. And you'll see also routine lab screenings. In fact, they've done so many screenings on this. I would question if this was intended as a physical because of the amount of screenings done during this visit. Your last chart here is in the emergency department. Keep in mind in the ED, you are going to be looking at elements of history and exam. And so this is where we would come over to our saved Novitas chart. We'll take our MDM away for a moment, and we'll be looking at elements of HPI, either by status of chronic conditions or the amount of elements documented, how many review systems, and how much of those past medical, family, and social histories are documented. We can see that they're here for back pain, and already in the reason for visit are some HPI elements. We have the fact that it's been going on for 2 days, which tells us about the duration, and that they were doing heavy lifting 2 days prior, which tells us about the context in which the pain started. There's a list of vitals, which would be counted into your exam elements. Assessments from the vitals, like the BMI, is calculated based off of their height and weight. And blood pressure and spirometry is also part of those vitals. There's nothing in the travel screening because it is denied, so nothing would be pulled from that. And your provider pulls in much of the same information that's already been listed, but in their own words. You have duration of how long they've had the back pain and the context of what was going on. They reported symptoms the next morning, which is actually a timing element because they're telling us what time of day they started having problems. It's a new problem. Again, they're repeating some of the same things. It occurs constantly. Associated symptoms include myalgias, so there is associated signs and symptoms. The symptoms are aggravated by bending and twisting, so modifying factors. When they bend and twist, it causes the symptoms to get worse. That would be a modifying factor. He's tried rest for the symptoms, which provides mild relief, which is also a modifying factor. And the provider reviewed over their allergies, past medical, surgical, social, and family histories, which in an EI chart is absolutely relevant for selecting all 3 of your PFISH. So what level of history would you pull from all of this? The review systems has 2 items. So that's your history. Under your exam, you have a repeat of a lot of your vitals which were already taken. I would take a look back here to see if there was any indication as to level of pain, because we saw those in some of the notes previously, but it doesn't look like anybody in the ER has selected that on this visit. Physical exam gives you some information about their overall appearance and specifically looking at the musculoskeletal of the lumbar back. And they've shown you exactly where on the, on the bottom right side of the back. They're talking about range of motion, tenderness to pain and spasm, impression when inspecting the back that there was no tenderness, swelling, or edema. So you have a couple of elements, but not a whole lot. And in the assessment section, you have two different diagnoses that are listed. One that is an injury and one that is more of a permanent condition. Discharge diagnosis and treatment plan indicates that the patient was given instructions for these medications that are assigned here, Toradol and Advil Motrin. And these are given by prescriptions when listed like this. They reviewed the dosing regimen and possible side effects, and has advised them to return to their primary care or a follow-up with a specialist if needed. And they've also marked down here the different areas that were reviewed, which is also important because it supports the history that we already said was selected. So based off of your 1995 history, then exam, and medical decision-making, you'll be looking at three different areas here. They're very similar to the medical decision-making we're used to looking at, and you'll bring it together here on your 5th page. By looking at the appropriate level of ER, you'll notice the ER is down here at the bottom. For a history, exam, and medical decision-making. Those are your 5 charts. Make sure to reach out to me if you have any questions during your discussion this week. And remember, your discussion is something where you take an attempt to code based off of the information that's provided. Make a review to see exactly what you coded and how it should have been coded, and then make an assessment and share with others on your findings. Sometimes you may find different things that can help you along the way. So have fun this week as you go through these 5 charts, and feel free to work together or reach out with any questions.